Sachin to open the session with a word of prayer. Shall we all stand up, please?
പ്രാർത്ഥിക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധനും സ്തുതി ആദ്യമേ എന്നേക്കും തന്നെ. ആമേൻ. സർവശക്തനും നിത്യനുമായ ദൈവമേ, സ്വർഗ്ഗസ്ഥ പിതാവേ, സംഭവബഹുലമായ ഒരു ആഴ്ചയുടെ ഞങ്ങളുടെ ജീവിതത്തിൽ കടന്നുപോയി. കഴിഞ്ഞ വ്യാഴാഴ്ച മുതൽ ഈ വ്യാഴാഴ്ച വരെ ലോകത്തിൽ നടക്കുന്ന കാര്യങ്ങൾ, ആക്സിഡൻറ്റ്സ്, മരണങ്ങൾ, യുദ്ധങ്ങൾ, യുദ്ധശ്രുതികൾ, സമാധാനമില്ലായ്മകൾ, ഇതൊക്കെ ഒരിടങ്ങളിൽ നടക്കുമ്പോൾ ഞങ്ങൾക്കാർക്കും ഒന്നും ചെയ്യുവാൻ കഴിയാത്ത ഒരു സമരത്ത് ശാന്തരായി ഒരു സ്ഥലത്ത് മറ്റുള്ളവരെ സേവിപ്പാൻ, വെറും ഒരു വില്ലേജ്, ഒരു ഗാവായിരുന്ന ഈ തിരുവല്ല, ഈ കുറ്റപ്പുഴയിൽ ഇതുപോലെ ഒരു മെഡിക്കൽ കോളേജും, പുതിയ പുതിയ കാര്യങ്ങൾ കേൾക്കുവാൻ, പഠിക്കുവാൻ, സമാധാനമായി സന്തോഷത്തോടെ ഇരിക്കുവാൻ അടുത്ത അരമണിക്കൂറിന് ദൈവം ഞങ്ങൾക്ക് തന്നു. ഈ വ്യാഴാഴ്ചയ്ക്കായി നന്ദി. ഇന്ന് പുതിയ കാര്യങ്ങൾ ഞങ്ങളോട് സംസാരിക്കാൻ പോകുന്ന ഡോക്ടേഴ്സ്, ആ കേൾക്കുന്ന കാര്യങ്ങളൊക്കെ ഞങ്ങളുടെ ജീവിതത്തിനും ഞങ്ങളുടെ വരുന്ന തലമുറയ്ക്കും ഞങ്ങളുടെ ചുറ്റുമുള്ളവർക്കും ഈ ഹോസ്പിറ്റലിൽ വരുന്നവർക്കും, അതല്ല അടുത്ത ജനറേഷന് തന്നെ സഹായിക്കുന്ന എത്രയോ കാര്യങ്ങളായിരിക്കും എന്ന് ഞങ്ങൾ കരുതുന്നു. കൂടെ ഇരുന്നിട്ട് സഹായിച്ചാട്ടെ. ഇന്ന് വന്നു ചേർന്ന ഓരോരുത്തരെയും ഞങ്ങളെ ഒരുമിച്ച് അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥനയുടേതിനായി സ്തോത്രം. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning, friends. We all have heard about the terminology osteoporosis. I'm not sure many of us from various clinical backgrounds, laboratory side. And osteoporosis is a silent illness which really leads to a lot of morbidity and even mortality if it's not diagnosed and treated at the right time. Especially this burden is more skewed in women, especially after the menopause stage. And it's a silent cause of fractures. Sometimes we don't even realize it's happening unless we screen. So we have had a few sessions on management of osteoporosis last year, but today we thought we'll bring in one newer facet of how we can integrately monitor the treatment, especially using the biochemical markers which we have called bone turnover markers. So it's a joint effort by the Department of Clinical Biochemistry as well as the Endocrinology Department. We will have our newly joined consultant, Dr. Malini Ajayan. Can you stand up? She's going to set the ball rolling. She's opening batsman for this session. And Malini and my colleague, Dr. Jaison from the Department of Biochemistry. He's an assistant professor, deputy registrar, and also doing a fellowship in metabolic medicine in our teams. So they both will be doing this session. And after that, Professor Kannan Vaidyanathan, I've requested him to sum up the talk and then open the open up the time for questions. So without wasting much time, over the next half an hour, let us listen to Malini and Aibel. If you have any questions, please feel free to ask at the end. Thank you so much. Over to you, Malini.
Thank you. Respected senior doctors and my colleagues and dear friends. First of all, I'd like to thank you for giving me this opportunity to start and end this session. Hopefully this is going to be a very enlightening session, and I welcome you to this week's quest. So before delving into the actual topic, which is bone turnover markers, I'd like to give a brief introduction regarding osteoporosis. Like how sir said, we are from different clinical faculties. So our concept of osteoporosis may be different. So I'll try to concise it as much as possible. So osteoporosis basically is characterized by low bone mass, some microarchitectural deterioration, finally everything culminating in a weak bone. Finally what happens is this bone is amenable to fractures. And why we are so concerned about osteoporosis is because this decreases the quality of life and increases morbidity and mortality in a very preventable scenario. And WHO defines osteoporosis as a very technical definition, when the bone density falls less than 2.5 standard deviation below the mean for a young healthy individual of the same age and gender. So this is basically called as a T-score. I'll just briefly talk about it when I talk about bone mineral densities. But right now, this is how we define osteoporosis. So if the bone mineral density is between -1 and -2.5, it is osteopenia. Let me come to that. So how do we identify the risk factors for osteoporosis? We'll have patients coming into our clinics from different aspects of life. So just look out for these factors. There are non-modifiable factors and modifiable factors. So non-modifiable being advanced age, female gender, white or Asian race, low peak bone mass, family history of osteoporosis, family history of fractures, and low BMI. And the modifiable factors being smoking, low calcium intake, inadequate vitamin D, low BMI again, estrogen deficiencies, hypogonadism, and chronic glucocorticoid therapy. Why I'm so hung up on modifiable factors is that, like the term indicates, it is modifiable. So we can actually intervene if we intervene at the right time. So there are some mandatory lab we always do in osteoporosis, but make sure that it includes the routine laboratory work like complete blood count, total calcium, phosphate, vitamin D levels, PTH, liver function test, and some special investigations like ESR, which is actually special in this scenario because we'll be ruling out multiple myeloma. Also some tissue transglutaminase antibody, serum testosterone in suspected patients with hypogonadism. And this is a very important slide because most of these individuals, which I have actually highlighted in that table, these individuals will not be coming to our OPD, they might be coming to yours. So who are you going to send for a DEXA scan? So women age 60 or older and men age 65 and older, even if clinical risk factors are there or not, you please ask for a DEXA measurement. And postmenopausal women younger than 60 years or men in 50 to 64 years age bracket, if you have any reasons to believe that they may have osteoporosis, because they may have a clinical risk factor, or women in menopausal transition who has clinical risk factors, individuals who've had a fragility fracture. So fragility fracture means the person sustaining a fracture in an otherwise normal trauma. I mean, it's like if the patient falls from a height which is less than his standing height, and in that kind of patients who comes in with a fragility fracture, please ask for a DEXA scan. And if there is any pre-existing conditions like rheumatoid arthritis or type 2 diabetes, chronic diseases that affects the bone mineral density, please ask for a DEXA scan. And any individuals whom you feel, it doesn't fit any of the bracket, but for the clinician's intuition, if you feel that the patient may have an osteoporosis, please go for a DEXA scan. So as we know, it is a DEXA scan is a dual energy X-ray absorptiometry. Basically what we do is we try and assess the mass of one material in relation to the mass of a surrounding material. Though it indicates density, we are actually checking mass per unit area because DEXA does not have a concept of depth. So this is how a normal DEXA scan looks in the AP spine. So we have mentioned this T-score and Z-score. I'm sure all of us know. I'll just briefly mention that T-score basically is comparison of that patient's bone mineral density in comparison with a person the same age as the same gender but younger age group, that is 20 to 29, and the comparison actually is associated with some Caucasian age group, Caucasian race, but that is one fallacy about DEXA scan. And Z-score is with the same age group. That is the only difference between T and Z, but it's very important when you come to interpreting DEXA. This is the DEXA scan of the hips. And with the DEXA, with the T-score, with that value, what we'll do is we'll go into what is known as FRAX, which is Fracture Risk Assessment Tool. Again, we all must be familiar with it. So this is basically an online tool which was developed by WHO to give us a 10-year fracture risk probability. And with this, we'll be calculating two types of fracture risk, which is the first one being major osteoporotic fractures, which encompasses all types of fractures like your vertebra, hip, forearm, and proximal humerus. So it gives us an overall idea about what is the bone's quality. And the hip fractures, that is an entirely different entity altogether because that is mostly associated with morbidity. FRAX comes with its own sets of limitations. So now we have what is known as FRAX Plus. Though they have not made it free, we have to subscribe for it. We also just want to point out that we have a new trabecular bone score method which is actually incorporated in DEXA. This gives us an idea about the quality. DEXA is only going to tell us about the amount. So trabecular bone score tells us about the quality of the bone, and there are some cutoffs as well. Once we are armed with the blood investigations, the DEXA, the FRAX score, we can directly delve into categorizing the patient into what category of risk they fall under. So you have low risk, moderate risk, high risk, and very high risk. This is very important because this is what determines what kind of treatment you're going to give the patient. So this is the Endocrine Society guidelines, initially developed in 2016 and then updated in 2020. The guidelines which help us choose the agent for treatment, whether it is an anti-resorptive or whether we have to start the patient on anabolics or whether it's a sequential therapy or a combination therapy. Now, these are all tools. This is by no way a replacement for a clinical intuition. So combine everything and then we have an actual schedule for osteoporosis treatment. Now that I have introduced a little bit about the osteoporosis part, I'm going to give this floor to Dr. Jaison. He's going to talk about bone turnover markers, the basic biochemistry.
Thank you, dear ma'am. Good morning, dear family. Thank you for the opportunity. I'll be dealing about the core biochemistry of bone turnover markers. Let's rewind regarding what's happening in the bone. So bone, the composition is with a matrix, organic and inorganic matrix. Organic matrix comprising of collagen and non-collagenous proteins and mucopolysaccharides. And inorganic matrix, which comprises the much part of the bone, it's comprising of two elements, that's calcium and phosphorus, and they combine together to form a compound that is known as calcium hydroxyapatite. Now, there are so many cells also: osteoprogenitor cell, osteocyte, osteoblast, and osteoclast. So the most important cells among these will be osteoblast and osteoclast. So the osteoblast, so it forms the bone. It secretes the osteoid. Unmineralized bone is what is known as osteoid. So osteoid is comprising of type 1 collagen mainly, and it contains non-collagenous proteins, to which the calcium hydroxyapatite crystals will be attached and we will get a mature bone. Osteocytes maintains the bone, it sends the strain, and it is formed from osteoblast. Osteoclast has got the most important function, that is the resorption of bone, and it is formed from the hematopoietic stem cells, but osteoblasts are formed from the mesenchymal stem cells. So there are three key phases for bone formation: osteoid formation, matrix maturation, and mineralization. Osteoid formation, osteoblasts secrete type 1 collagen and the ground substance, and the ground substance are the non-collagenous proteins also, osteocalcin, osteonectin, etc. Matrix maturation, collagen fibers organize and they will form the cross linkages. Then mineralization, calcium and phosphate form the hydroxyapatite crystals within the collagen scaffold. Okay. Now the osteoblast secretes two important compounds. One is rank L and another is osteoprotegerine. Rank L is receptor activated nuclear factor kappa lambda ligand. It activates rank in the osteoclasts, so it has got an important role in the osteoclast development. At the same time, this osteoblast secrete another protein, that is osteoprotegerine, which inhibits the activity of osteoclast. So osteoblast has got a tight regulation on osteoclast. Now regarding the collagen in the bone, mostly type 1 collagen, and it provides the tensile strength to the bone. Okay, it is the most abundant protein in your body, and it is produced as pre-procollagen. Then it is transformed into procollagen. Then it is transformed into tropocollagen. Why you have to know is, during this phase of division, this formation of mature tropocollagen, there are some peptides which is releasing, which is actually the bone turnover markers. So now you can see that this is the triple helical structure of our collagen, and every third amino acid in the collagen is glycine, and it's X and Y. It's usually GXY like that. So X is proline and Y is hydroxyproline. Now something regarding the bone remodeling cycle. It happens throughout your life. Every day there is bone remodeling happening. So the cycle of bone remodeling is carried out by the basic multicellular unit. This is the bone remodeling unit, that is otherwise known as BMU, which consists of a group of osteoclast and osteoblasts. Together they have a coupling reaction. They are a couple. So the process of bone remodeling is initiated by the recruitment of osteoclast precursors. So what is the stimuli for the bone remodeling? See, the osteocytes, they mature and they die. That's one stimuli. When we are exercising strenuously or we are handling a big object, there will be some minor cracks. Again, that's another stimuli. So the process of bone remodeling is initiated by the recruitment of osteoclast precursors. These precursors will be forming the multinucleated mature osteoclast. And this osteoclast adhere to the bone and it subsequently undergo acidification and proteolytic digestion. And as the BMU advances, the osteoclasts leave the resorption site and the osteoblasts move into the cover of excavated areas and begin the process of new bone formation by secreting the osteoid, which eventually is mineralized into the new bone. So, comprising what I said is, there will be a resting state, then there will be activation of the osteoclast, then there will be the resorption of the bone, then there will be a reversal, then there will be a bone formation, and at last there will be mineralization. So the normal bone remodeling cycle is like this. Micro damage occurs, then activation of bone remodeling, osteoclast resorption, osteoblast formation, mineralization, and balance turnover. Now, in normal, there will be the bone resorption is equal to bone formation. But when it comes to the osteoporosis, you can see that there will be increased osteoclastic activity, that the resorption is increased, but the bone formation is deficient. Your peak bone mass will be attained at the end of 30 years, at the third decade of the life. After that, we know that there will be resorption is more and the bone formation will be low. Okay. So why bone turnover markers in osteoporosis? Reflect the active bone turnover, early monitoring of treatment effect, and potential to predict the fracture. Bone resorption markers and bone formation markers are there. Bone resorption markers are the most important will be the CTX, C-terminal telopeptide of type 1 collagen, and the osteoclastic enzymes like tartaride-resistant acid phosphatase and cathepsin K. Now, the bone formation markers are P1NP, that is propeptide of type 1 collagen, procollagen. Then there are some matrix protein osteocalcin, then one of the most important enzyme, osteoblastic enzyme, that is alkaline phosphatase. Now, we will be starting with the markers of bone formation. Alkaline phosphatase is produced from osteoblast. So, it is a phosphatase, so an alkaline. It is active in the alkaline pH. So, the action is by enzymatic degradation of the inhibitor of mineralization, that it inhibits the pyrophosphate at an alkaline pH. So, it lacks specificity and also sensitivity only because alkaline phosphatase has got 6 isoenzymes, and the most important among for the osteoporosis or the bone turnover activity, to measure the bone turnover activity, is bone specific alkaline phosphatase, BSALP. The second marker is osteocalcin. Again, it is produced from the osteoblast during mineralization. Only a proportion of newly synthesized osteocalcin appears in the circulation. It reflects the osteoblastic activity. It is produced by other cells also. It constitutes 15% of the non-collagenous bone matrix, and one of the most important point in osteocalcin is under carboxylation of osteocalcin reflects as a marker of vitamin K deficiency. So what are the limitations? It has got a short T-half, unstable intact molecule, and it is under the influence of vitamin K status and influence of renal function. Now, the important another biomarker is procollagen 1 N-terminal propeptide. And we know that by the synthesis of collagen happens from pre-procollagen to procollagen to tropocollagen. The procollagen will be converted to tropocollagen by cleaving the N-terminal and the C-terminal peptides. Now, this N-terminal peptide is used as the biomarker for osteoporosis. Most P1NP in the circulation is derived from bone due to the high turnover. Exceptions will be the post-surgery when the healing tissues release excess P1NP, skin diseases, and in liver fibrosis. The measurement is usually by automatic analysis using ECLIA, electrochemical chemiluminescent immunoassays, and radioimmunoassays. The advantages being low intra-individual variability, smaller circadian variation, stability at room temperature, and good assay precision. So nowadays, as a marker for bone formation, we are using P1NP. Now, what are the markers of bone resorption? So we can see that this is the mature type 1 collagen at the top. And the type 1 collagen will be cleaved by the osteoclast by the enzyme cathepsin K. And it will be producing two telopeptides, C-terminal telopeptide and N-terminal telopeptide. So, we are utilizing these as the markers for bone resorption. When CTX and NTX are first formed, the amino acid sequence is linear. After a few months, the CTX is C-terminal telopeptide, undergoes the beta isomerization, that is peptide backbone moves to the beta carbon. CTS is otherwise known as, commercially it is known as beta cross-labs. Why it is known as beta cross-labs? Because the beta forms reflects the more mature collagen, and cross-labs indicates the cross linkages in the collagen. So beta cross-labs is none other than the CTX. So it is the most frequently used bone resorption marker. So it has got a difference between NTX also. NTX is actually the specificity and sensitivity of NTX. N-terminal telopeptide is low, so we must use C-terminal telopeptide. Plasma C-terminal telopeptide has been recommended by International Osteoporosis Foundation and IFCC, International Federation for Clinical Chemistry, as a reference marker. Another marker is pyridinium cross-links. We know that the collagen is comprising of so many cross-linkages, right? Now, one of the cross-linkages is pyridinium or pyridinoline, deoxypyridinoline cross-linkages. So again, that can be used as a biomarker. Okay. But it is less used currently because the assay is compressed on. It has to be analyzed by HPLC, high performance liquid chromatography. So in the normal setup, we will be using CTX and P1NP. Okay. Now another bone resorption marker is tartarate resistant acid phosphatase type 5B, otherwise known as TRAP. It is a marker for osteoclast cell number. So it is one of the important osteoclast marker or the resorption marker. Another marker is cathepsin K. Okay. Now, very recently, IFCC and International Osteoporosis Foundation in March 2025, they had a consensus update on the role of bone turnover markers in the diagnosis and management of osteoporosis. By their directions, these are the markers that can be used for osteoporosis, for the prognosis, to assess the prognosis. Because these bone turnover markers cannot be used as a diagnostic marker, it can be used as a prognostic marker to assess the treatment activity. So P1NP and BALP, bone specific alkaline phosphatase, are being used as the bone formation markers. C-telopeptide and TRAP is used as the bone resorption markers. So there are some issues regarding the collection of bone turnover markers for analyzing. As Madam said, there are modifiable factors and non-modifiable factors. So it is imperative that we have to collect the samples after an overnight fasting, usually from 6 to 8 a.m. And the variations, we can see that the peak will be at 6 a.m. and another will be 6 p.m. Bone turnover markers in men will be more than women up to menopause. After that, the bone turnover markers activity will be increased for women. ALP is not influenced by the diurnal variation. Recent food. Why you have to be fasting? Because food consumption, it suppresses bone turnover markers, and exercise also suppresses bone turnover marker. And fracture, if you have a fracture in the last 3 or 4 months, it will result in high bone turnover markers. And a newer terminology is BSI, that is bone strength indicators. It includes various regulators of bone metabolism not directly involved in the turnover. They are valuable for research, not yet standardized. So these are the bone formation regulators, sclerostin and periostin. In the coming future, we will be actually doing these things to analyze the bone activity. Sclerostin is secreted by osteocyte and it inhibits the bone formation. Periostin, it's a periosteal matrix protein. It have the predictive activity for the fractures in postmenopausal women. And another key emerging markers will be Wrangle, osteoprotogerin, ST14, S1P. So we will be seeing in the coming future these all bone markers. Another hormonal markers we are using nowadays is FGF23. It has got an independent predictive value for the fractures. FGF is fibroblast growth factor 23. It's actually a phosphaturic hormone. Now, another marker will be circulating amino acid valine. It is linked with reduced hip fracture risk. Circulating microRNAs, miRNAs. This is a publication in JCEM. Circulating microRNAs are as biomarkers for osteoporosis. It's from this study, microRNA 23A3P and microRNA 21,5P differentiate osteoporotic versus non-osteoporotic activities. Okay. So there are some limitations for the new bone markers. They are still under research. So this comprising of the biochemistry of bone markers. Thank you. And I invite Dr. Malini for the continuation of the presentation.
Thank you for this beautiful presentation, Dr. Abel. Now, we've heard a very precise description of bone turnover markers. Now, let me give you a few pointers regarding how we can use this information in our day-to-day clinical practice. Where to order a bone turnover marker and where to withhold. Now, so this is basically the role of bone turnover markers in treatment of monitoring of osteoporosis. So, Sir has explained very well about the bone resorption and the bone formation and the imbalance that happens, which is the basics of osteoporosis. So bone turnover markers, I don't need to actually give this slide at all because there is no need for an overview after this beautiful presentation. So let's just skip through. Okay, so bone turnover markers, and not only, I just want to emphasize on this point that even though we are talking about osteoporosis as such, bone turnover markers can also be used for an exhaustive number of conditions. Though the data may be limited, the research is still undergoing. So all the things given in the table, that is glucocorticoid-induced osteoporosis, CKD osteoporosis, Paget's, hyperparathyroidism, pediatric conditions, multiple myeloma, immobilization, multiple number of things, or even anorexia and malnutrition, bone turnover markers are now being used for now probably in research stage only, but then probably in the future we might get standardized data. So not just limited to osteoporosis as such, this is a very expansive topic. So the BTM in osteoporosis in a clinical practice, basically we all know that osteoporosis basic causes are primary and secondary. And the norm is that in primary osteoporosis, the bone turnover markers, if you ask for an baseline bone turnover markers, no, they may be normal or increased, mostly normal. But secondary osteoporosis means the metabolism is so high that the bone turnover markers are almost always going to be very high. So one explanation for asking for a baseline bone turnover markers is to differentiate between primary and secondary, which if we know the common causes of secondary osteoporosis, we can even order other tests also, but this is a very good adjunct to differentiate between the two. And now for actual osteoporosis, what are the areas where bone turnover markers have deemed to be useful, whether they are actually useful or not? So for prediction of bone loss. Now we all know postmenopausal women, once they hit that age, after the estrogen starts dropping, and the higher there's going to be rapid bone loss, and the higher bone turnover markers are going to come from all sorts of bones, like especially the spine, the total hip, femoral neck and radius. And this, surprisingly, the bone turnover markers, they correlate better with a cortical bone loss rather than trabecular bone loss. Trabecular bone, though, has higher metabolism. The cortical bone is actually, the sheer amount of cortical bone is so much higher than trabecular bone. The bone turnover markers always mostly depend upon the cortical bone loss. And you need serial bone turnover marker measurements. We can't just be satisfied with one, but we have to have the idea to correlate it with BMDs also. But the sad part is that as far as prediction of bone loss is concerned, almost all the associations have been moderate only at best. So we don't have a proper clinical utility as of now. There have been some studies. The best one so far is a trio study in 2004, where they showed only some sort of weak association between P1NP and total hip loss, and CTX and total hip loss. So right now, for prediction of bone loss, bone turnover markers are not very useful. And rather, for prediction of fractures, we commonly in our clinical practice, we use FRAX tools. And when FRAX is unnecessary, and if we can have the access to it, FRAX Plus also. Can bone turnover markers be used as an adjunct? Yes, it has a very significant association, but it is kind of modest. So again, we need multiple more research on this particular area. But now that we have FRAX, we are more or less happy with it. So for prediction of fractures, that it has a limited value in clinical practice as of now. All this as of now scenarios might change in the future. So all of this is now just some disclaimer. I'm just giving a disclaimer that it might change in the future. Now, one of the major studies in this area was the EPIDO study. So that this small diagram shows that the relative risk of hip fractures are high for somewhat between 1 to 2 for low BMD, just low BMD, for about 2 to 3 for high CTX markers. But when you combine both, so if you have a low BMD and high CTX, the relative risk is almost doubled. So here, this basically tells us that if we ask for a bone turnover marker along with DEXA, this actually gives us a very good idea regarding whether the patient might develop fracture in the future. Now we come to the core part of it, that is the using bone turnover marker as a guide to selection of treatment and also prediction of response. The last two conditions have been, like I said, there's only limited value. What about this condition? So at the beginning of the therapy, so patient walks to you, you have diagnosed osteoporosis. Now when to order for a BTM and why to order for a BTM, that remains the question. So normally we would expect that if the patient has high baseline BTMs, we expect that the metabolism is too high and this patient will respond beautifully to anti-resorptives. And the opposite probably will be true, that if they have lower BTMs, they might respond better to anabolic agents. But that is not always the case. There have been conflicting results. So these are the major studies which showed this conflicting results. So for this point also, for the selection part also, even at this point, we are conflicted. So there is insufficient evidence. So the ultimate thing is that there is insufficient evidence to tell us, to support this use of routine baseline bone turnover markers to select a mode of therapy, whether it's an anti-resorptive or predicting the treatment response. So then why are we here? Why are we discussing about bone turnover markers in the first place if none of these things have a proper association? The core of the topic is that this will help us in monitoring the response. Now, if we have a DEXA, all institutes have DEXA. So if you have DEXA, why do you need a lab investigation to help us? That's because DEXA comes with its own sets of issues. So when we are giving a patient an anti-resorptive, it takes about more than 1 to 2 years for some sort of change to come up in the DEXA, so that you can calculate the least significant change at the end of 1 year or probably 2 years, depending upon the patient's response. So then should we wait for 1 to 2 years to see if the patient is going to be okay or not, or should we wait for a fracture to come in? That's not a very practical way of dealing with things. So DEXA comes, the second thing is that one of the major indicators in DEXA is the spine. Now, spine, as we know, is not only associated with osteoporosis, almost all sorts of degenerative diseases affect the spine. So the quality of DEXA, the kind of reading, becomes very skewed. So at this point, we cannot completely rely upon spine also. So once you've started your patient on a treatment, how do you monitor? So DEXA is not going to be a foolproof method. That is where BTM actually comes in, and that's why we are discussing this in the first place. So when you are starting the patient on anti-resorptives, which is the most common, two of them, there are two common treatment modalities. So when you're starting on anti-resorptives, which is mostly zoledronate or denosumab, you see that there is a decrease in the bone resorption markers, which is a dramatic response. Then after some time, when the bone resorption reduces, the bone resorption is married to bone formation. It's a couple. So one reduces means the other thing also reduces at some point. So the bone formation also suffers after some point. Then this results in a decrease in the bone formation markers. Now this is the basis of why we give drug holidays to a patient. We cannot indefinitely send the patient on zoledronate as much as we want, because at some point it will turn back and bite us. So resorption markers should decline by 1 to 3 months because osteoclasts respond so fast. But formation markers typically take some time to decline because the coupling comes a little slow. And that takes about 3 to 6 months. And the least significant change depends upon which assay we use, and that for our bone turnover marker, we calculate it by 2.7 into the coefficient of variation depending upon the assay. And if you have a response which is greater than the least significant change at the end of this particular 3 to 6 months for a resorption, for a formation marker, or 1 to 3 months for a resorption marker, you know you are going in the right way. You have 95% confidence that you are actually in the good right now. So bisphosphonate is one of the most frequently used first-line drugs in our clinical setting. So that is now, BTMs are now used for assessing the adherence to therapy. You put a patient on oral ivandronate, they go home, they might come back after 3 months, and we don't know whether they've been taking it or not. This might help us if we have a baseline and then another anti-resorptive, BTM at the end of 3 months. So the suggested markers in this particular background is CTX and P1NP, and one of these markers or both, depending upon the patient's condition, before initiation will help us get a baseline value. And you repeat it at 3 months, and if your decrease in the bone turnover marker, it exceeds the least significant change, this patient is a responder and not a slacker. So that's a great thing for us to know. BMD at 3 months, we are not going to get any sort of evidence from BMD. And the responders, so what basically is this, we can't calculate LSC and 2.77 and that and all is very difficult to calculate in a clinical setting when the patient is sitting in front of you. So how do you calculate? This is an international data which tells us that if there is a decrease of P1NP of 10 nanogram per ml from the baseline, the first one, or if the absolute value is less than 35, then that's great. And for CTX, this is the decrease of more than 100 nanogram per liter, or if it goes to below 280 nanogram per liter, the absolute value, we are in the good. So if we don't have to remember 100 different points, these 4 things, if we remember, we have enough and adequate data. I'll just say a few words about our Indian data, probably in the coming slides. So, like I said before, osteoclasts take the brunt of everything, so the CTX changes occur earlier, much earlier than the P1NP, though you should order for both technically. When you're ordering denosumab, so that's a 6-monthly injection, as we all know, there is a rapid decrease of CTX because, again, osteoclasts take the brunt, and that rapid decline is basically by 86% in the first month and about 72% at the end of 3 years. P1NP is a slow person. He's a formation marker. No, so he's coming in a little slowly, and that he hits a nadir at about 6 months. But and at the end of 3 years, however, he hits a loss of 76% at 3 years. So even when the patient is on denosumab, do not think that your bone formation markers are not important. Send for both. It will give us a very clear idea. And another problem with denosumab, however, is the risk of rebound. As soon as you stop denosumab, what you see is that the osteoclasts come back with a vigor, and they are going to peak, and the CTX will peak, and this peak happens in 6 months after you discontinue the denosumab. So after you stop denosumab, are you going to sit with idly thinking that we have managed to end the resorption, to end all resorptions? No, that doesn't happen like that. We have to think about a sequential therapy. That is where the zoledronate comes in. So if you are fairly convinced that the patient, we've stopped denosumab for a patient and this patient needs to be on a sequential therapy, then the CTX will help us with that. So this, when we see that the CTX values have gone through the roof, this is an indication for us to start the patient on zoledronate. Cheaper drug, very commonly used in all our OPDs. So this bone turnover markers technically needs to be used every 3 months after you discontinue denosumab. So if that CTX value, the absolute value is more than 280 and the P1NP value is more than 35, which means things have actually gotten out of hand, please give an additional dose of zoledronate. And the duration of zoledronate. So how long are you going to give zoledronate? And that duration depends upon the increased BTMs. After some time, you'll see that the BTMs start coming down. Then you are okay. You have not managed to harm the patient. And the third drug, which is a current favorite of all endocrinologists, is teriparatide. It's an anabolic drug. It's not an antiresorptive, it's an anabolic daily injection. So anabolic drugs means P1NP is your go-to bone turnover marker. So P1NP you have to do at the baseline and also at first and third month. And what is that we are looking for when you are looking at the serial gradation? What you're looking for is an increase in P1NP of more than 10 nanogram per ml and an absolute value of more than 69. Previously, I was saying everything less than. Now, this one is more than because this is an anabolic drug. P1NP is bound to increase. And at 6 months, BMD should be assessed because this is, again, we need to assess the whether the patient is responding on a skeletal level. We need to have an imaging also. And after 2 years, both P1NP and BMD measurements should be used together to decide how to proceed with the sequential therapy. We all must be knowing about sequential therapies. Anabolics drugs are always followed by antiresorptives. So this is like a normal bone turnover marker that we usually ask for in our OPDs. It's just idea regarding, so this, when we ask for a CTX and P1NP, this is how the reports look like. This is just an example of it. Now, all of which I have told you about the international data. Now, our problem is our Indian data, we don't have much data regarding Indian studies, so we extrapolate with international studies. So Indian studies is that ISBMR, that is Indian Society of Bone and Mineral Research, they have said that BTM is complementary to BMD, but they have no role in the diagnosis of osteoporosis. So for the monitoring part, we use CTX and P1NP, and we check it before treatment at baseline, and then at 3rd, 6, and 12 months for both antiresorptives and anabolics, an additional of at 1 to 3 months. And here we use a decrease in CTX by at least 30% or the 100 or a reduction by 100 nanogram per ml, same like before. And for P1NP, same, an increase by more than 20% for anabolic therapy or more than 10 microgram per liter from baseline. But this is not useful for combination and sequential therapy, so we won't. I just wanted to end the presentation by just mentioning about use of bone turnover markers in pediatric population. We may have pediatricians sitting among us. So though using bone turnover markers, we do not have standardized data, but it is now being touted as one of the most important investigations we do in case of pediatric osteoporosis, which is a very much a ground reality. It's not uncommon, it's not rare. So, but the problem with children is that it's like trying to repair a moving car, because a child skeleton is always growing, always remodeling, not like an adult skeleton. So the challenges are extreme. So we need larger pediatric cohorts, and there is also study issues because recruiting children brings up with some sort of ethical aspect, blood draw and all, and assay dependency is not all that good. So, but in certain special conditions like glucocorticoid-induced osteoporosis, prolonged immobilization, prolonged vitamin D deficiency, patients on chemotherapy, all of these conditions, BTM can be asked for. Just that standardized assays need to be a little more accurate. Also, CKD, we commonly see chronic kidney disease patients. We all know the association between kidney disease and osteoporosis. The problem with CKD patients, we have dime a dozen CKD patients coming to a hospital, and they might be suffering from various stages of osteoporosis. The problem here is that the normal CTX and P1 and P, these are dependent on a functional kidney. So when the kidney is lost, the CTX and P1 and P tends to get accumulated. You send for a baseline, it is going to be sky high. So previously we used to manage the osteoporosis in CKD by seeing the PTH levels. Now that is also skewed because PTH assays tend to be the bone skeletal activity in CKD is actually very volatile. It can be from hyperthyroidism induced bone loss to adynamic bone disease. No, we can't predict what is happening. So bone turnover markers help us here, specifically two bone turnover markers. That is your total ALP, bone specific ALP, and P5B. Now these are not affected by the functional or non-functional kidney. These are good indicators in CKD, as Dr. Abel has already told about it. And combinations also increase the diagnostic accuracy. I think I've taken 5 minutes more than was given to me. Thank you so much for your patience. I will conclude by now. Thank you so much.
Thank you, Dr. Malini, for the excellent talk, and for Dr. Abel as well. I'm going to request Dr. Kannan Vaidyanathan to just sum up what we heard in a simple way so that we can have some good carry-home messages with it.
Thank you very much, sir. I think there is no need for summarizing further. Dr. Malini and Dr. Abel have done a wonderful job. They have summarized, actually, Dr. Malini has summarized the whole thing at the end. So essentially, we have been last 1 hour, we have been hearing about the different aspects of bone turnover markers and osteoporosis. And we all realize that osteoporosis is an important condition. And as far as the diagnosis is concerned, well, as we heard in the last 1 hour, the bone turnover mark, BTMs have no role for the diagnosis. For the diagnosis, you need the bone mineral density measurements as per the DEXA scan, etc. But then we all also need to monitor the treatment, because there, as Dr. Malini rightly pointed out, the DEXAs have a difficult role because it takes time and there are lots of constraints, and that is where the BTMs play a role. But then you can't rely much on BTMs also because of so many variations which occur in the measurement. Lots of markers are there, as you can expect in any biochemical investigation. Not one marker is enough. You need a combination of different markers, etc. And obviously the cost to the patient is also a concern. So taken all together, we can say that DEXA should be used for the diagnosis of osteoporosis. And then when you are monitoring treatment, whenever you want to see the patient's response to the different treatment modalities, what Dr. Malini was telling, we can use a combination, a judicious combination of the bone turnover BTMs. So that's what would be indicated. And that's, I believe, the conclusion, what I understood from the two talks. Excellent talk by both the speakers. And before I hand over to the open to the floor for the discussions, if anybody is interested to have a look at the position paper, the paper which Dr. Abel was telling, it's written by my good friend, actually my brother should say, Hardirpal Bhatova from Hungary. He's our main author, and Sam Vasigan is also a good friend of mine from Australia. They have written essentially this paper, this position paper, which are from IFCC. If you're interested, I can share it on the doctor's page. Because why it's important? Because there are lots of variations. That's one thing. If you're using BTMs, there are lots of biological variations in including vitamin D, for example. If you're taking vitamin D supplements, calcium supplements, all these will affect the BTM measurement, BTM interpretation. So if you are using BTMs, caution should be taken, and this paper essentially gives all the details of the various things which should be taken into consideration. So I open the floor for discussion. Any questions from?
Thank you, Dr. Kannan, Dr. Malini, and Dr. Joel. Regarding this denosumab, does it actually increase the risk of femur fractures and spine fractures silent fractures. Is there I seem to have read somewhere that denosumab has this side effect where it actually increases the risk of fractures.
Sir, to the best of my knowledge, it does not increase the risk of fractures while you are on it. But when you discontinue it and when you send the patient for drug holiday, you are supposed to reassess the patient, call the patient back in intervals and see if there is a drastic reduction in bone mineral density. So sequential therapy is basically advised for that. So all anti-resorptive, especially denosumab, should be followed by a course of another anti-resorptive, most likely zoledronate, if the patient requires it. And if the patient is otherwise stable, the BMD remains stable, no much risk of fractures and falls, we can just reassess the patient. While the patient is on denosumab, I am not aware of a fracture risk, sir.
Thank you, Dr. Malini. Any other questions?
Thank Malini and Abel for that. Abel, I'm discovering more and more about you. So it was fantastic. Thank you so much. You know, I just wanted to mention to all of you, just recently, Lydia has done a reel on osteoporosis, which has 583K in just a few days. So obviously this is an area that the people are very interested in. So maybe our physicians and all those who see our patients should be a little more, we need to probably do a little more in that area, because it appears as though our people are very concerned about this and they'd like to know more and more about it. Thank you. Thank you. I hope I could have understood a little more, but I can't say.
Thank you, sir. Any other comments or questions? Youngsters, I'm sure you have lots of questions. And this is actually a good area for research as well, for any PGs in clinical subjects or even basic subjects. It would be a good marriage between the clinical and preclinical subjects. We are talking about marriages the whole day. So it's a good marriage. It's a good opportunity, because we have come up with this plan of marrying endocrinology and biochemistry, and it is working out very well, I should say. And it's actually a good concept, which if any of you PGs from clinical subjects are interested, medicine or allied specialty, because osteoporosis is entire, like kidneys again, chronic kidney diseases, so many things it is affected. If you are above 50 or let's say even 40, you are prone to have osteoporosis. So it affects geriatrics, anybody is interested. I hand it out to Dr. Philip.
So thank you, Dr. Kannan. I just want to also mention that we have the DEXA facility, we have BTMs, but we find it is grossly underutilized in our institution. Probably many of us need to build more confidence in using it, especially the physicians, rheumatology, orthopedic teams. We need to use our facility more. When we audited our DEXA usage a few years ago, it was very low. Only 2 DEXAs a day for an institution of our stature. It's probably a very underutilized. But now I know the graph is steeply rising. I request you all, if you have any questions, we would be happy to come and do CMEs within your departments so that we get confidence to order and utilize the available resources. So thank you so much to the team Biochemistry for partnering with us in this quest. I'll hand over to Dr. George Chandy to invite somebody special.
Thank you, Philip and Kannan. I just want to once again emphasize that our strength will be in interdisciplinary work. So I hope there will be more presentations like this. Ashwin is somewhere here. Should have been here, yeah. So there should be more interdisciplinary work. You're here because of Malini. But let's have a lot of interdisciplinary work where the preclinical and paraclinical people are waiting for the clinicians. So please go over. You have a central research laboratory, lots of facilities just there for you. Please, please, I request you to make use of it so that in the coming year we'll have lots of activities which don't happen in other places. So you have a good breeding ground. Please make use of it, is my first request. Second is, Renu Matthew here won't stand up and speak. So on her behalf, I'll tell you there are lots of books she's prepared downstairs in the courtyard for the next 3 days. Please go and have a look at it and see what you want from it. About 7 years ago, a handsome young man who I got to love, I got to care for, I wanted him as my brother or my son. 3 years he was with us, and then after that, he said he got into All India Institute of Medical Sciences. So we said goodbye to him on study leave. And then 6 months later, and I know all this partly because my son became his mentor. He said, I don't want All India Institute. I said, this is the top institution in the country. How can you leave that? He said, no, this is not the training I want. He dropped an All India Institute seat and said, I want to really learn endocrine surgery. And so he wrote the NEET, got into Madras Medical College, followed the example of Anish Sugunan, who had already won the gold medal and was the topper there. And he topped the university in the exam that was recently held. And because he was away on study leave, he decided that there was a lot of offers from all around, but he said first choice will be to come back home. So please put our hands together and welcome Dr. Mano Zach Matthews. Thank you, Mano. I think Mano, in my opinion, epitomizes all that we wrote, bringing hope and healing and compassion and care. So it's lovely to have you back with us. You want to tell us something?
Thank you so much for your kind words, sir. And very good morning to all. I mean, I feel really happy to come back to BCMCH. It feels like coming back home. And really looking forward to a really good time with you all. Thank you.
So thank you everybody for coming, and hope we see you next week, same time, same place. Thank you. Have a good day.